Hi, everybody, and thanks for your interest in TB. It's the smallest room, but we filled it, and that's very, very positive sign. And don't forget, this is a hybrid session, and therefore we expect a number of more people joining us here today in the afternoon. Can I have the first slide, please? Oops. Anyway, so I wanted just to remind you that the UN high-level meetings rarely really covered health issue before COVID entered the stage. There was one on non-communicable diseases, one on Ebola, AIDS, antimicrobial resistance, and in 2018, indeed, TB made it to this high-level meeting. And I wanted just to remind you what the major remarks were on that meeting, because I think it's now time to take stock and see where are we now, what did we achieve, and where are the missing issues which we have to achieve, because the clock is running, as we all know. 2030, that's the timeline, and that's nearing fast. Next slide, please. Oops, yeah. Can you have the next slide, please? Oh, I see. I get the duty to do that, and somehow. So that was a kind of got it. So that statement, which was adopted by the General Assembly, so all members agreed on it, and they clearly stated the commitment to end TB in 2030. In line, obviously, with the WHO goals of sustainable development. We committed, our countries, our nations, to end the epidemic in all countries, and we affirmed that TB is the leading cause of death from infectious diseases. You may argue that has changed with COVID-19, but let me also remind you that over the last 200 years, 1 billion people died of tuberculosis. And if you just take the average, that's 5 million per year, so that's about the numbers. Obviously, latest years have about 1.5 million deaths. It's not the number one, but we don't want to argue about that too much, because it's still 1.5 million deaths, too much. It's the most common form of antimicrobial resistance globally, and it is the leading cause of death of people living with HIV. So the commitment was to advance research for basic science, public health research, and development of innovative products and approaches, and obviously integrate cooperations between private sector and academia to get new, safe, effective, equitable, affordable, available vaccines, point of care, child-friendly diagnostics, drug susceptibility testing, and more effective drugs and shorter regimens. And I'm sure this is one of the topics of positive results over the last years to look at that. And all age groups should be involved, from youngest children to adolescents and adults. So this costs a lot of money. Now, since COVID-19, we talk about different sums as we did before. And I think this is also an issue we should have on the table today, how much money should be invested, because I'm sure we will hear today, every investment results in a lot of return of investment. So at that time, we were talking about $2 billion or euros to close the gap between what we have currently, or in the last years, of 700 million or so, to come with an estimated 1.3 billion in addition, and to strengthen all the different aspects from academia, science, public health, laboratory capacities, which are all needed for prevention, diagnosis, treatment, and care. And that's more or less what I wanted to say in the beginning. And I wanted to welcome you once more again for this hot topic, I would say, although it is an ancient topic that comes up every now and then, it remains a hot topic. And I'm very proud and glad that we have such a wonderful group of participants here. And now here are the rules. Everybody on the panel will talk about 5 minutes or so. We will have then a few minutes if necessary for burning direct questions, but then come up into a global discussion, which will be devoted most of the time to, which is discussions with the panel and with you in the audience, be it here face-to-face, at site, or be it, because this is a hybrid meeting, somewhere in the world. And with that, I thank you all and would like to ask Lucica to start with her words on TB. And I think she's one of these persons who are strong advocates, what has to be done.
Thank you. Thank you very much. Yes, thank you very much, Professor Kaufmann. Thank you very much for you being here. I want to thank Professor Kaufmann for putting forward this session here at the World Health Summit. There are not too many discussions on tuberculosis this year or in other years, but it's good we have this one. And I want to thank all of you for being here in the room. And I'm very happy to see, first of all, maybe because of the mask, I don't recognize many people because I hate preaching to the choir. And very often in TB meetings are always the TB people. So we speak to each other how bad it is and nobody else cares. But I'm happy also to see a lot of young people, and that is not influenced by the mask, because then I have hope. There are some people that can take this work forward, because what you see here is a panel of old friends and old fighters. Maybe less Lindsay. She's young, but she is also old in this business. Huh? So it's not that you just joined. Huh? A lot of a panel of old friends fighting for many years to not to end TB, but to really put the world on track to end TB, as you heard. And we are not in a great spot right now, as you heard. We are also not in a great room, to be very honest. TB is an airborne disease, okay? Like COVID, we have a low ceiling room with a carpet here. It's good we have the mask. So that's, I cannot deny. But where I try to go is to the fact that I hope what we learn with COVID, we will put in practice. And I know Willow will touch on that a little bit, but also we'll put in practice to help with TB, because TB and COVID are both airborne. And when COVID kicked in, everyone actually relied on the TB doctors, on the wards of TB, on the laboratories. So when it was a crisis, the TB services, as good or bad as they were in a country, were very helpful. Now, we also want to benefit something from that, isn't it? And we learned that is possible. So it's good for you to know, I saw some of you and Professor Kaufmann spoke about the number of people that die of TB and the number cumulative over the 100 years, looking surprised. Every single day, we have 4,100 people dying of TB, 700 of them are children. But it looks, these are several planes every day. Now, if you would see that there are 8 planes that crash or 10 planes that crash every single day, everybody will be up in their hands, right? A plane crash, and we are desperate. But we don't see these kind of figures. And that's why we don't know. With COVID, even the weakest countries in the world were able to put on the corner of a television and on every single channel, how many people were tested for COVID, how many died, how many women, how many children, how many with blue eyes, somebody with long hair. A lot of data. You know, with TB, we function with more than a year-old data. If you ask me now, okay, what happened last year? I cannot tell you. I will be able to tell you just at the end of the month when WHO issues the formal report, which is not just for TB, it's for the rest. And that, so at the end of October 2022, we can tell you, not just me, all of us, the data for 2021. It's like you ask me, can you tell me how will be the weather tomorrow? I'll be like, no, but I can tell you how was last Sunday. It helps for nothing. It's, of course, good for publication, but it doesn't help for the program. So what we should aim for nothing less for people with TB than for people with COVID, right? We should aim for live data. We should aim for rapid testing. We should aim for access to all the tools. We should aim for a new vaccine. All of this, we should aim with what? With money. And what happens is that we had good predictions. And by the way, for those of you young here, you want to publish, you can reach to any of us or to me. There is a think tank called Copenhagen think tank that is looking at the cost efficiency of interventions for the SDGs, and they are coming out with a report. Tuberculosis is the best investments for the treatment. For every $1, you get $47 back. It's like you put your money in a bank, you get for $1, 47. Now these days, you know, you put $1, you get nothing. You actually need to put more. So to get 47, it's a good investment because TB is cheap to treat. But in spite of that, in spite of having a good investment case and so on, we are in a very dire situation. So we have the WHO strategy says ending TB by 2030. Okay, we have a time frame. It's the same, the Sustainable Development Goals, as you already heard, end TB as well as HIV and other diseases by 2030. We unpacked and we have some investment cases, the global plans, that are taking a certain amount of time. So we are looking at a new global plan that we did with a lot of people, experts, 2023 to 2030. So for the next 8 years, a huge amount of resources to the level of 200 billion in total for 8 years will be needed for research, but also for scale up to be able to put the world on track. Now, that sounds like a very big amount, but do you want to hear something before you are all, wow? 100 billion were made available in a year for COVID, in one bloody year. Huh? But you know why? I am usually politically incorrect. Some of you know me. I will become even more famous now and make more friends because TB, unfortunately or fortunately, put it as you wish, it doesn't affect people in the big north. It affects people, a lot of people in the big south. And even there, the poor in the poorest country is, as we say, people with vulnerabilities there. Who cares? Why should I bother? Why is it impossible for us in TB to have a vaccine? We have a vaccine for 100 years. You know what I mean? Like what? And we are now in a pipeline, Mel here, and everybody can tell you, we have now a pipeline with some 14 candidates, let's say 8 that are good. It took us 15 years to arrive here. And we should be able to get a vaccine in 3 years, but we need the money and we need the money to be visible and to exist. So the title of what I was supposed to say, which I didn't, was, do we have the possibility to close the gap to end TB? So what I want to tell you is what we have is less than half. So for every one of you that leaves this room today, you need to have this thing that these people in TB have now some tools that they can scale up and can reach to the level that we will decrease. We will not end zero, but we will decrease. They have some tools now. It's not a vaccine, but we can get a vaccine as well. What they don't have are money, because what they try to do is to reach 100% of the target with 30, 40% of the money. It's like you want to go from here by car to Munich, and you need to fill the tank, and you say, nah, I put just 30%. So you know from the start that you will not reach, but you are like, okay, I'll start anyway. So what do? You will end somewhere and then you try, you push, maybe you advance a few meters, but you will never reach the targets. The money in TB are coming from the domestic resources, which is unfortunately pathetic, especially in Africa. In Africa, most of the African governments put into their national, their own TB programs, less than 10%. There are African governments putting from what is needed in their country 2%. Like you better say no money for TB. What is that 2%? So that's one pot of money. The other is the Global Fund for AIDS, TB, and malaria, which is the biggest external donor for TB, but because of whatever reason, mainly political, TB gets the smallest amount, even though kills more than HIV and malaria together, okay? But it gets 18%, HIV gets 50%, malaria gets 32%. So we are, with this 18%, at around 700 million per year, as you heard from Professor Stefan Kaufmann. And with this money, we don't go too far. There is a huge gap left. So the answer is there is a huge gap left. The second part, is it possible to close the gap? Absolutely. Because we saw that money are not an issue. We saw that it's possible to mobilize billions if we want to. We saw how countries, when it's about war and machines and everything, are able to mobilize billions. So it is possible. It's just important for people to care and to believe that we can do it. And when you leave that door tonight, if you doubt that money cannot be mobilized for TB, you need please to come to speak with me, because I have a little stick to hit you with. Thank you very much.
Super. So this has set This has set the stage clearly. You know what to do from after that session on, but we will go on and listen to the other speakers. We'll get a little bit more on the technical side and start with diagnostics in a broader sense. And Willow Brock from FIND will give a kind of an overview and tell us where we have to go, and perhaps also what COVID-19 has helped us to rethink in the diagnosis of TB. Before you start, I promised if there is a very urgent question directly to Luchika, but don't ask her to give another talk at this stage because she's coming back to it. Otherwise, we'll go on with the next speaker. And thank you so much again. You set the stage.
Thank you, and I'll stay here. That might save us a little bit of time. Thank you very much. I'm Willow Brock. I'm with FIND, the Global Alliance for Diagnostics. I'm not with TB Alliance. For those of you who I can't recognize behind the mask, I will try to talk about diagnostics, not about drugs, because my old boss would do that. I've been there for 2 years now, and I'm glad to be here in Berlin, starting with TB, basically because of love and because of there's a lot of progress there. So my question posed to me was, where did COVID-19 lead us in diagnostics? And the good news is, notwithstanding the parallels and the problems that are in those parallels, is that in diagnostics there's an enormous amount of progress over the last 2 years that we can leverage. First of all, for those of you who've been around for more than 2 years, we realized that we were all talking about Cepheid. We're just basically talking about gene expert and maybe about the next generation gene expert. Nothing against Cepheid. I don't know if they're in the room. But now we have molecular platforms that are way advanced from what Omni was promising us to do in a multitude. So I took one today, for those of you who can see. I'll stand up. This is basically a next generation molecular diagnostic test, the PCR test, in 15 minutes. It has a $2 insert in which you put a swab sputum sample, and it can do up to 7 tests in parallel. And this is just one of the 11 investments that we made that you see here. We did a landscape of about 150 new diagnostic platforms that are that we hope that we are able to see to come to market. Most of those were developed for COVID, as you can understand. But a relatively small investment in assay development, like in any other molecular platform, will actually make them available for TB, and not just for TB. You could see all kinds of combinations, pneumonia and TB, a big issue to distinguish in many countries, should be able to be done from the same sample with the same test in 15 minutes. And the price of this machine is about $300. Maintenance is pretty much minimal. And as I said, the test is about $5 with markups. The plastic itself and the content would be about $2. So this is really quite good. So we got molecular platforms reaching point of care, true point of care, that you can take in a backpack, in your inner pocket, and bring it to a community health station. They are all connected. Each one of the ones that we've invested in has connectivity, which means they'll automatically be able to report back into public health reporting systems, potentially overcoming the problem that Luchika talked about. It's like, why on earth would I wait 16 months to know what happened in TB? What am I going to do with that data? With this type of new technology, you would have that available immediately. There is, however, a lot of work in ensuring that all these different platforms can talk to each other. It's obviously not in the interest of manufacturers to have connectivity with other platforms. So there's a role for a broker in between to ensure that these go together. On the same time, we are seeing a lot of progress in how specimen collection can be done. I mean, we all know that this is a big issue in TB. Certainly, especially true for children, for people living with HIV, and we've seen a lot of progress there. I'm just going to rapidly through this. So these are already 2 new platforms that are on the market since the introduction of Gene Expert. So we now got 4 platforms on the market. The 2 of them come from Korea, and the MolBio one is already on the market, but is actually developing the new Ultima chip, which will be able to do more resistant testing, and clinical trials are expected to read out by the end of this year. let me just show you this picture. We've had an interesting collaboration with the University of Leicester where we created this new mask technology, and you see the head of the TB program at Morton Down, who had actually COVID. He put on the mask for about 15 minutes, took off the strip that you see on the second one, dissolved it in a few milliliters of water and put it on a rapid test, and it showcased exactly the right results. So a aerosol collection device, which is a mask, which strangely enough, everyone is here. We could just have this type of mask. Price would be about the same as a regular mask, a 95 mask. You sit here for an hour listening to me and Professor Kaufman and Lucica, and however much fun that is, at the end of the day, we could just take the strip off and have you all sample without any extra work done. So there is an enormous progress potential in the way we can deal with samples, and that we can progress that in TB. We've seen the first artificial intelligence enabled application for interpretation of lung photos. There is AI enabled stethoscopes. There are cough apps that are starting to become really quite better, and therefore screening tests would be making an enormous progress as well. All of these technologies weren't developed necessarily for TB, but all of them are very simple to adapt if there is some money for the application in TB. Finally, also the skin test, and finally the eyeglass have actually made some progress, and there's some work done, especially in India now, to develop a next generation of tests that, even with the use of the famous vaccine for the last 100 years, there's a lot of people that can't use the old test. These ones would be able to distinguish infection even with a BCG patient. And then there's some companion technologies to sort of link them all up and ensure that that data gets put together. That's really it that I wanted to start with. So yeah, TB remains the top infectious disease killer. That the diagnostic gap is dramatic, but the opportunities are massive. The new instruments, new technologies, new sputum, the replacement for sputum, they're all there. Maybe I'll stop there.
Thank you so much. Thank you. Wonderful. Wonderful. So there are no burning questions, but I have a look around. Later, I guess I will better stand and have a better look. No, yes, there's one, just to the case.
Hi, my name is Venkat. I have a quick question. So you said sputum collection, specimen collection, and transfer.
We are hybrid, and therefore we need the micro. Yep. But
So
go on.
you mentioned that specimen collection and transportation is a challenge. But do you have any say innovations to display, or say any inputs on the same?
Well, so some of the examples I mentioned. So the mass technology that would be able to have aerosol collection. This is one of the areas that is being worked on. There's obviously new recommendations from WHO for use of stool in children. There's the new generation. There's the LAM tests that are there for people living with HIV, which are still honestly not performing extremely well, but there's now a second and third generation coming up that being tested. So third generation LAM is being tested, which should be making be able to use urine as a sample. So yes, there is potential breakthrough on all fronts of being used. Whether they can come to success, I mean, this is R&D. There still has to be research done, but we're definitely hopeful that this is a feasible strategy for expanding test options.
Okay, one more, just be brief, please.
Yeah, very brief. So you said most of these nucleic acid technologies were not developed for TB. I'm assuming they were developed for COVID, but sample preparation is a big difference between COVID and, I mean, the swab and the sputum. So how are these technologies addressing the complex sputum sample and extracting the DNA before doing PCR or nucleic acid testing?
Yeah, so this is part of the research that's being done. Bioneer, for instance, has already started. They are one of the ones that has one of these technologies, and they've already started developing a TB assay. So it is about the ability to amplify the sample in the technology. Also, the way that the new swabs are potentially better. So there's a range of different swabs that were tested during COVID that are now being looked at, is sort of which ones are better in terms of collecting the right type of sample. So again, lots of work still needs to be done, but the amount of progress, thanks to COVID in the last year or two, has been dramatic.
Yes, and one very last, very brief question from Lucica.
No, it's actually adding to his answer. that we should not necessarily just rely on transporting the sputum. We should bring the diagnosis closer to people. Because during this COVID, we realized that keeping it where it was, it created complications. So we speak a lot in Stop TB and all of us about reimagining TB care by bringing diagnosis closer to the footstep, and having a tool like that combined with a portable X-ray machine with artificial intelligence, combined with some of this that you can do tests for diabetes, for blood, for, you can really have a mini lab that can be stationed in front of the hotel, figurative, and then you can go there and you can be tested. And it's already happening like that in several countries. We can discuss a bit later. Like, yeah, bring the diagnosis closer.
Okay, thank you. And we will go on. This sounds, sorry, I have to go on now, and in the later we will find time again. I try to be as, but anyway, so next we'll now actually another success story, in my opinion, and that's we have Mel Spiegelman from the TB Alliance here on TB drugs.
Stefan and everyone here, thank you very much. I'm going to do what's not appreciated by most people and deviate a little bit from the script. And the title of the talk that the brief talk that I proposed is a quote from someone we all know very well, Albert Einstein. And that quote is that insanity is doing the same thing over and over again and expecting different results. And over the past 20 years or so that I've been in the TB field, I think this has been a hallmark. Now, have we made progress? Absolutely. Willow has described progress. Luchika has. Lindsay will describe even more progress. We've made tremendous progress in the ability to treat MDR-TB from 18 months down to 6 months, et cetera. And all of that is obviously great. Will we eliminate TB in 2030? My prediction is unfortunately not a snowball's chance in hell that TB will be eradicated by 2030. I also don't like to, if I look at the statistics that are at least are available these days, after a brief 2.5 years or so of COVID, TB is again the leading infectious disease killer on a day-by-day basis because of the tremendous progress that has been made in COVID, but not because of 2 billion. Luchika addressed it, but a log difference at least, if not 2 logs difference. And that's what it takes to truly eradicate or even come close to eradicating a disease. So what's my take-home message on this is that we need radical, truly radical changes in how we do virtually everything in TB. And that starts not only from securing the financial resources, Luchika addressed that. We can't just walk into a high-level meeting, everybody puts a number on the table, and 2 out of 100 keep their promise, so to speak, of that number. That is not the way to proceed at the next high-level meeting, because it simply doesn't work for a disease like TB. We need to radically change the way we do advocacy, lobbying, research and development, and so importantly, which was the lesson from COVID, in how we ensure equitable access and equitable availability of all the new products and all of the rollouts that we have. That's the challenge that we've got. We're not going to solve that here today, but I just want to present that to this audience at least to say that is the challenge that we have. It's not what I would call tinkering around the edges. It's a fundamental rethink of how we really solve the TB problem. And one of the things that I would really defer to Stefan and other experts on is it is my bias that TB, especially compared to a disease like COVID or certain viral diseases, is truly eradicable. That is a really important issue that we have not, I believe, made enough prominent information about. If you look at all sorts of the scientific and the immunological and other characteristics of TB, and this is obviously for a broader discussion, with the right input and with the right resources, it is possible to truly eradicate TB within a reasonable period of time. And I know we sometimes like to use that as an advocacy tool, but I believe it is truly true and something that we have not taken advantage of in the TB field. So, you know, and I think, you know, Willow and I are best friends from my perspective. It took 1.5 years to get a point of care COVID test into the hands millions of people around the world so that they could do a test at home whenever they wanted to for a very reasonable price with reasonable government involvement in so many countries. I have heard of a point of care test being a top priority for the 20 years that I've been in TB. Are we getting closer? Yes. Is it going to happen so that somebody can do it at home within the next 10 years? I'm not completely sure when we look at all the stages that still need to be gone through. So I certainly want to, you know, not leave with a negative note. Others will also speak about the tremendous progress on such bare resources that have been made. But that's only evidence that if we had the right resources, this disease would be eradicated. Thank you very much.
Thank you. Thank you, Mel. And this was also a wonderful start into the discussions afterwards. Questions, comments, specific questions, comments, I should say. Yes, we're down in the back and one here. And as I said before, then the general discussion will be much more broader. Yes.
Thank you. I would like to thank you, Dr. Papasek from Senegal. I'm the advisor of the president of Senegal in charge of animal health and global health security. My question goes to animal TB, bovine TB. I would like to know the device you show previously. Is it if it's work for bovine TB, but to diagnose bovine TB too? So I would like to know also if the expandable are also cheaper than the device itself, because $300 is for me is really affordable. But my question is if the expandable also are also affordable for us. So because I think that if you want to really defeat TB, to eradicate TB, I think that we should have this kind of device and send it to the remote areas and do routinely diagnosis to be able to detect all TB cases and heal it. Yeah, thank you.
Okay, quick answer. So the test that we've invested in, all of them, this is the test itself. This is about $2 cost of COGS, probably a $5 test. And this is at the moment at a reasonably low volume, still what we expect all of it to be. There's an interesting piece of work that's going to come out on a much more macro level around screening and diagnostics from India, done by the Center for Global Development. The question is, if we're thinking at scale, how much would we need to invest to be able to eradicate TB? And I think if you think about the 1 to 47 return on investment, if you're looking at the technology we now have, we have to dare to think big. So when that exercise started, I was thinking, how are you ever going to do 400 million tests in India? But it's possible now. And I think that is what we will now see, right?
India was vaccinating 25 million every day.
Yes.
So it's reachable. They need to have the money and the will.
So let's go on with the, oh yes, sorry, very brief. We need the microphone up. Oops, here's one as well, otherwise, oh, she's coming. Please, to the point.
Yes. Hello.
Yeah.
Yes, I'm very far from you. You couldn't see me. Thank you. Right.
Well, you
I was going to say there are countries without TB that have very low cases of TB. if you compare, say, highly populated countries like China and India, which one has more populations of TB? What I'm getting at is do we really need not only this technology? What did those other countries do that we need to do in countries with high level TBs? It's very important. That's what we need to repeat and go that way as well, besides this good technology. Thank you.
So I see Mel nodding, and I leave it to him to give a first answer. And I guess that's something we will come back in the general discussion.
Yeah, no, it is ironic in a way, because it's the middle income countries who really carry the majority of the burden of TB. And from my perspective, they do invest somewhat in caring for their own populations, somewhat, but the ability to look at it from a global basis and really carry their fair weight for a global basis isn't there, frankly. And I think that's one of the initiatives that has to be embarked upon, is that all countries in the world carry their fair share of what it will take according to their resources, et cetera. And some countries that are even very poor, frankly, can provide a lot of resources in terms of that's where the patient populations are to be tested. That's an invaluable resource also. But we need truly innovative thinking to put this into a comprehensive package and frankly, sell it and enforce it.
There, TB somewhere, TB everywhere. Next speaker is Carlos Castilleos from Johnson & Johnson, J&J, and will give us a kind of overview on the drug treatments developed with J&J activities.
Yeah, thank you, Professor Hoffman and fellow panelists, for having me here. It's a privilege to have a seat at this table with such esteemed colleagues. And it's also for me a privilege to talk about, the role of that industry can play on this space. I was asked to talk about the role of industry, but instead of doing that, I'm going to talk a little bit about the way we see our role in this particular disease. And the distinction is because I think not every pharmaceutical company will approach the problem in the way we are. We built a dedicated unit in J&J that it's called Global Public Health, really with the aim of not only developing drugs that for diseases that disproportionately affect people living in low and middle income countries, but also we're privileged because internally we're measured by the company in terms of lives impacted and not necessarily dollars we sell. But we develop a drug after many years of no new developments, no new mechanism of actions in the space of TB, and it was not an easy task. It was a complex mechanism of action. The regulatory pathway was quite unclear, so we had to invest significantly at risk. But long story short, we developed this drug, which was approved in 2012. And we then went through the regular process of having EMA approval, having it pre-qualified by WHO, and we started donating the compound. We donated 100,000 regimens of this drug, and it was not being used for many reasons. And we didn't understand those reasons at that point in time. So we start working with many people around the table to better understand what we had to do to actually enable access. It was not about only availability and affordability, because at that point the drug was being donated and still it was not being used. So we had to better understand the policy side of things. We had to better understand that we needed to develop local data, local evidence in the countries where the compound will be used, and not only focus on the small phase 2 trials that we had that were used to get this compound approved. And it was not until we generated that evidence that we could start helping informing the guidelines of individual governments and WHO. And that gave us the opportunity to start partnering and unlocking global and more local procurement mechanisms and expand the accessibility to the drug. So based on that experience, we built this new group, relatively new in 2016, that we call GPH. And we believe it's a unique model because the model is lab to last mile. We have a dedicated R&D unit, which is focusing on diseases that, again, disproportionately affect people living in low and middle income countries. We have the traditional business that is focusing on the other areas. We have an oncology we have an immunology one, a CVM, but we are exclusively focused on those areas those diseases that disproportionately affect people in low and middle income countries. And because of that, many of these have been market failures, so not many other companies are interested in developing assets in this space. And then we talk about the last mile because of that learnings that we got from bedaquiline, in which developing a drug or a compound is not enough. We have to do a lot of local evidence generation. We have to extremely collaborate with partners if we really want to move that needle. The last thing I think we have to do is to have a long-term commitment in the space. It took 40 years to find a new target. Fortunately, we were talking about that earlier with Lindsay. We have now in a moment in which we have many other options, many other new targets that are being assessed, but it's not an easy space, and it's easy for people to get discouraged about continuing investing in mechanisms of action that won't always get to light. So I think it's very important that we continue collaborating intensively. At this point in time, after 10 years of having launched launched that compound, more than 500,000 people have been treated with full regimens of bedaquiline, which is, in our estimation, about 75% of the people in the MDR space that should be getting access to this type of compound. So it's not an easy task, definitely not one that individual pharmaceutical company can approach or solve. So I think it calls for extreme collaboration around the different entities. And for that, again, I want to thank for the opportunity and the continuous collaboration with everybody here.
Thank you. Direct question down here. Yep, down here means more or less in my vicinity. Thank you.
Sebastian Schönherr from University Hospital Leipzig, infectious disease researcher and global health researcher. Yeah, you mentioned that you are measured by the impact you have on health, and that's fantastic. But I do wonder why bedaquiline, when it came to market, was priced out of range for a lot of countries. You mentioned that you donated it, but to me, it seems much easier to just set the price low so people can just buy it right away. And I know that in many countries, price was an issue for bedaquiline, including India. So yeah, maybe you can give a statement to that.
Yeah, we donated about 100,000 regimens of the 500,000 that had been, or more than 500,000. So you're absolutely right. More regimens had been sold for a price. That price is not a unique price that we set in the developed markets. It's a price that has been negotiated with governments across the globe to ensure that is a fair price for the situation. It's a complex matter, again, because we need to establish what is the specific situation in each country. Unfortunately, we have been able to partner with groups like the Global Fund to set a price that has enabled now more than 157 countries have access to bedaquiline through global procurement mechanisms that can facilitate accessibility on a global basis. We have what we call a tier-based approach to ensure that the price that it's paid is according to the specifics of the different countries where the compound is being used. And I think that's a very important element of ensuring equitable access to innovation like that. And lastly, the last point I would like to make is that 10 years after we launch this product, and we start selling this product a few years later when the donation was over, 10 years later, we were still running studies. We were still running studies in pediatric population. We're developing formulation for pediatric population. We have active surveillance for resistance in the countries to ensure that if it's resistance for bedaquiline, we can see it and we can address it in a proper way. And the investment that we have done and from the sales goes back into medical education, into evidence generation that is addressing the evidence needs that the policymaker and academics need to better inform the guidelines.
Thank you. This is pricing clearly is a difficult and controversial. We may come back in the general if there is interest in the audience and discuss that in more detail. There's one more brief comment or question.
So my name is Calvin and I'm from South Africa. I have a question about the vaccine pipeline. I know you guys are doing drugs, but is there any possibility that are you researching TB vaccines? Because I think one of the problems with TB is we can't treat ourselves out of it. We're just not, and
Yes.
We've seen that in the past 2 years, we've had 114 COVID vaccines in the pipeline, whereas with TB, we only have 14 at the moment.
Yes.
So we need much more robust
Can I
vaccine
ask
pipeline.
you to come back to that in the general discussion? Because I wanted to say 2 or 3 words. If they're not coming up here, I feel that I'm good enough to talk about vaccines. And thank you. I will not forget that, unless others will cover it in now in the next round. So thank you again. And I really look forward to lively discussions on the later part of this round. It's all very, very promising. Lindsay McKenna from TAG, Treatment Action Group, and I'll give the podium to you. Yeah.
Great. Thank you so much. I think there have been a lot of good analogies made, and so I'll borrow one from a TB activist who some of you may know, named Timur. When we talk about what we need to do by 2030 and the resources we have, he says something to the effect of like, yeah, we need a Ferrari to get there, but we have enough money just to buy a bike. And so I think, if you look at the progress that we've made over the last 2 decades of investing in research and development, it's incredible if you consider that we only had the money to buy a bike, essentially. So in the last 2 decades, especially in the areas of TB prevention and treatment, we can now prevent TB in as little as 1 month and cure most forms of TB in 4 or 6 months, which is a huge improvement over what we had previously. Still, and I think you've heard this from Mel and Willow and Luchika and others who have spoke, we need additional investments so that firstly, all populations can benefit from these treatment advances that we've made. There's populations that are still left out, including children and pregnant people. And we also need to continue to build on them, to iterate on them, to make treatment even shorter and safer. But beyond that, we desperately need to invest in better TB screening and diagnostic tools and interventions to close persistent gaps. And also to feed candidates into the TB vaccines pipeline and advance those that are promising through late-stage trials and ensure we have the basic science and the tools that we need to evaluate their efficacy. And to start working early to ensure that we don't have another situation when we do finally get a new TB vaccine where there's a vaccine apartheid in the global South. But all of our investments in R&D and the resulting scientific gains are only meaningful if they benefit the communities that are most affected by TB. And governments have this responsibility to ensure access to the benefits of scientific progress and its applications. And this is a human rights issue enshrined in the Universal Declaration of Human Rights and international human rights law. And yet, if we look at almost any new TB tool or intervention that has been introduced and has come out of our investments in R&D in the last 2 decades, adoption and implementation by national governments has been unacceptably slow. If you think about when bedaquiline was first introduced, that was 10 years ago when I first started working in TB. And countries, it's still a push to try to get them to use it at scale. And there are many reasons for this, especially insufficient funding for TB, which Luchika touched on. And governments are ultimately accountable for providing these benefits of science, but we know that there are other stakeholders, including at this table, that have roles to play in helping to take down barriers, hindering more expeditious and broader uptake of advances that come out of our investments in research. And that's very much the thinking behind a new civil society-led campaign called 146 by 24. The 1, 4, 6, each standing for the shortest WHO recommended TB prevention and treatment regimens, and the 24 offering a deadline, the end of 2024, for getting everything in place we need, what the late Dr. Farmer referred to as the 5 S's: stuff, space, staff, system, support, needed for short course regimens to be made available to everyone, everywhere as a human right. I think something, that is at the core of the organization I work for, TAG, is that communities that are engaged in research and that understand and have benefited from science are best positions to advocate for continued research before their governments and other funders, and for the uptake and adoption of future research outputs. So we need to do a better job making sure that communities can access the benefits of the last 20+ years of investments in R&D if we expect them to join us in advocating for the resources we need for the Ferrari to shepherd in the next generation of scientific advancements in TB, including a new TB vaccine. Thank you.
Thank you. So it's the churning again and again that we need a better funding system and more awareness of the TB issue. Questions, comments to Lindsay? Down here, please. Directly. To the...
Thank you. At first, I didn't say my name. I'm Dr. J.C. Mangwiro. I'm a physician, diabetologist. I work for the Ministry of Health, Zimbabwe. Lindsay said you need a Ferrari, but now we have a bike. What I'm looking at is, yes, treatment are those that have had the disease. If we have a lot more bikes, which is prevention, by what are the cheap methods or ways of preventing TB? We all know if an individual is taught, it's much cheaper than ending up with the Ferrari. The Ferrari is the end result. Let's have as many bikes. If the bikes are many, they can buy even many Ferraris. So it's very important that we also concentrate on prevention. We all know the reasons why people get TB and why it's more common in certain societies and not others. We all know. Let's attack that area as well as we advocate for the Ferrari. Thank you, Lindsay. It was a good talk.
Yes.
Just to respond quickly, not that it needs a response, but I think in the new Stop TB Partnership Global Plan and the modeling that it contains, they showed that if we want to end TB by 2030, we can do everything perfectly in terms of diagnosis and treatment and prevention. But if we don't have a new TB vaccine, we're not going to hit the targets. And so I think, we really need to rally around that, because we can do everything else perfectly. And we know we're far from doing that, but without the vaccine, we're not going to hit the target.
And I just want to add, I just want to drop here something. You see, for years in TB, we hear go with the bike. You know what I mean? For years, we are on the bike or around the bike. The other diseases, and I'm referring a lot of HIV/AIDS, is on Ferrari for tens of years, huh? And we are still compared with that. But if you go in Africa, the head of state, including of Zimbabwe, sir, will speak very easy about HIV, but will have probably zero idea about TB. We'll have zero idea the relation between TB and diabetes, which is a huge issue, right? And not you, I said the head of state. Not you, I'm saying the head of state, because the Africa is full of national AIDS commissions linked to the presidents. Tuberculosis is dealt by a program that is led by a deputy or a deputy of the Department of Communicable Diseases. Zero visibility. We tried the bike. We saw that Ferrari is given to other people. The life of a person with TB is as important as the life of a person with HIV or COVID. And it is time, as a revolution that Mel was saying, that we stand up for that and we don't accept anything less. Because if I die of TB or of HIV or that, I should have access to the right things in the right time, in the respective if I'm from Zimbabwe or Romania or Ukraine or Rwanda. Thank you.
We all agree, but so these were all wonderful presentations. I mean, wonderful probably is not the best word, but very impressive, very vital presentations. And so it's our last participant of the panel, Dr. Soumya Swaminathan from the World Health Organization, who will look at it from a WHO perspective and beyond, I would say.
Thank you, Stefan. This on? Yes. Yeah, so I think a lot has been said. Let me try and reflect on some of the issues and also what WHO is doing and how we want to work with everyone, all the partners to advance this field, because it's clear that we need advances. I, as the chief scientist at WHO, saw what was possible during COVID. We were working with scientists around the world, around the clock, and people came together spontaneously. Of course, billions of dollars were poured into R&D by governments as well as by private companies. And we see, all of us see the results, right? The point of care tests, the huge number of vaccines with different platforms that were developed, and so many of them already proven to be safe and effective, and still ongoing research on nasal vaccines, on pan-coronavirus vaccines. I mean, there is an ambition. Now, there is the pandemic accord that's being negotiated, and there is a hope, a plan for a 100-day plan to make a vaccine in 100 days, if and when there is a next pathogen that comes as a pandemic. But TB is a pandemic, and it has been for a long time. And we've heard today that the number of lives that are being lost due to TB is just not recognized. It's just not on anybody's mind. We also have seen what the COVID pandemic has done to TB. We've seen increases in deaths for the first time in a decade. We've seen reductions in case finding, case reporting. In 2020, we had the lowest ever reporting, 5.8 million of an estimated 10 million new cases. And we're also seeing trends of increasing incidence and one of the drivers, by the way, which I think has not been mentioned, because we also have to think upstream. A lot has been said about prevention. One of the modes of prevention is what are the risk factors and determinants of TB. And of course, HIV is a risk factor that drives in sub-Saharan Africa, but in many other parts of the world, including India, it is undernutrition. 50% of the TB cases in India, the population attributable fraction for TB is 50% in India and South Asia, whereas globally it's about 20%. Of course, there's diabetes, there's smoking and alcohol, but all of much lesser risk. So that's why we talk about the multi-sectoral framework, because if we don't address the increasing poverty and undernutrition, again, due to COVID, and due to all of the other economic risks, probably we're not going to make a dent. So we mustn't forget that. But then we also have to use the tools we have and look for the new tools, as has been mentioned. One thing we have done is to accelerate our guideline development process. I think it's been criticized as being slow, as being taking many years to bring the latest evidence. We've now moved into what we call the living guidelines approach, where we are doing constantly updating the systematic reviews. And I think we've seen in the last 2 years in the field of diagnostics and in the field of treatments, the new WHO guidelines have come very quickly after the clinical trials have announced their results. So Lindsay mentioned the 1-4-6, 1 month of preventive treatment, 4 months of treatment for drug-sensitive TB, and 6 months for MDR TB. These are huge improvements over what we were previously. But the fact is that implementation is delayed. Even though the guidelines come out, the implementation is delayed for a number of reasons. And I think we should probably discuss why it takes so long for TB guidelines and to change in countries. I want to say a little bit about technology transfer, but I also want to talk a little bit about vaccine at the end. A question was asked about bedaquiline, and there was this discussion. And I hope that from the experience from COVID, again, one of the lessons that we learned, we tried to address through the ACT Accelerator and COVAX was not to repeat the same mistakes of the past on the inequities and the time it takes for innovations made in high-income countries to reach everywhere in the world. And I think we made some progress by shortening the time that, took 10 years for the AIDS drugs, HIV drugs. It took only, I think it was 30 days or less between the vaccines, or 40 days being used in a high-income country and a low-income country, thanks to COVAX. But we faced a lot of challenges, no doubt. And one way to address this is decentralized capacity, both for R&D and for manufacturing. And that's why we now have this technology transfer program, starting with mRNA, but we want to extend that across the board, not only vaccines, but drugs, diagnostics. We need manufacturing capacity. And again, domestic investment is going to be important in addition to the investment that comes from outside. And it's good to see the leadership of the African Union and Africa CDC in this regard, and many African heads of state in really wanting to establish this framework. But again, it can only work if the innovator companies will agree to do tech transfer at the right time. And there are mechanisms to do that. The medicines patent pool, for example, has been successful in both HIV as well as TB and hepatitis drugs, but this needs to be done more quickly, transparently, engaging the manufacturers in the South. This not only brings down the cost, but also expands access. And I think this is not a mistake we should repeat. So again, a plea from WHO to all companies that are innovating. A lot of the investments are made by governments in the early stage research. There is no research which turns into a drug or a vaccine where the early research is not funded through taxpayer money, through public R&D. And therefore, there is a responsibility of the private sector to, especially when it comes to life-saving products. We're not talking about designer handbags here, which can be sold at any price. We're talking about life-saving drugs and vaccines. And finally, on vaccines, I hope that Stefan is going to say more, but clearly, we are not in a good situation. And it's true that without better vaccines, we may not see the end of TB. So we need much more in the pipeline, and the pipeline has to move faster. We need more clinical trials. Look at the way we advanced during COVID. We did these large platform multi-country trials. In a few months, we were getting results. The solidarity trials, the recovery trials, the anti-COVID platform that DNDi runs. Many platforms have been established. Why not make use of these platforms and have the existing drugs in the pipeline, vaccines in the pipeline move into multi-country trials? We need a global move, something like the ACT Accelerator, to come together, all the global health agencies, private sector, and national governments to say, we want to advance TB vaccines. And in the next 5 years, we should advance as many, because we know all of them are not going to be highly efficacious. A few of them may be, but again, we have new platforms. But I think the issue for TB is not really the platform. I don't think the mRNA is going to solve the problem. It's a question of the complexity of the immune response and not having enough information on correlates of protection and so on. So there's a lot of basic science, and Stefan is best placed to speak to that. But I think unless we fill the pipeline and keep it moving, it's taken 4 years. The M72 vaccine results came out 4 or 5 years ago now, showing 50% efficacy potentially of course, in a one population of TST positive individuals in Africa. That hasn't advanced to phase 3 trials. I mean, neither the company has been interested in advancing it nor any other agency. So the speed at which we're moving is far too slow. What the WHO is doing is working on something we call the evidence considerations for vaccine policy, because for a TB vaccine to be introduced at a large scale at the population level in a country, in an endemic country, would need considerations of cost effectiveness, of pricing, of procurement, or the regulatory pathway, which populations, when, where, etc. And now we've had experience with adult vaccination. I think, as Ruchika was saying, it can be done if we want to do it. But thinking in advance of the regulatory pathway, the policy pathway, and the procurement mechanisms would help us speed through. So even as we're doing the clinical trials, we need, and we're developing that that pathway as well. And then, of course, we need, finally, I would say, a complete rethink of the way in which I think we've thought of TB transmission in the past, as well as this whole concept of latent versus active TB. I think more and more research is now showing that it's a continuum, that there are various stages of TB, from being asymptomatic but infectious, minimal symptoms, to florid TB, which is what today we detect and treat. But there are all these people who are spreading TB. I think TB prevalence surveys, work done in South Africa, etc., has shown that there are lots of people spreading, are infectious, not detected. So our case finding approach also needs to change. We can't wait for people to come to the clinic. We need to be out in the community screening. That again goes back to resources. So if you're going to do mass screening by X-ray or by using Gene Expert or other molecular tests, you need the resources. But again, I think the science, we have to take the science more seriously. And I think even the paradigms of latent, as I mentioned, are changing. And we need to identify those people who are in that continuum, who've already got incipient TB or subclinical or whatever we want to call it. I think we have to also talk about some definitional issues, which again, there are going to be meetings convened to discuss that. So there's a lot of science, again, from COVID and from other immunology that we've advanced on, that need to be harnessed for TB. But I think what we need is a global a commitment and at the highest level. So hopefully we will convene some heads of state, etc., at the World Economic Forum next year to make those commitments. But I think it needs people, citizens asking for accountability as well. Thank you.
Thank you. Very comprehensive overview, and I see a hand in the middle. Now we go to the stage.
Hi, I'm Amy Logan from Humana People to People Federation. I've heard it's been touched on by a few of you, but there's nobody at the table from a community. And even if we have all of these things, all of the diagnostics, a vaccine, without affected communities and civil society, we cannot eradicate. I also think it's eradicable. I have two quick questions. I'm not sure who's best placed to answer them, but what is happening outside Global Fund and Challenge Facility awards for civil society? Is there advocacy happening for more funding for that? And secondly, where do you see the most need or ways for civil society to prepare themselves in order to support rapid rollout of these tools once they become available?
Soumya, you want to respond? Or
I think Luchika would probably.
Luchika would be the best one.
But I take your point, absolutely. Yes, we have to have.
So currently we are still with the direct questions, comments, but we will soon go into the general discussion. Was there another hand raised?
I can answer her.
Yeah, you please do though.
Yeah, okay. So 2 points. Don't even get me started with the civil society not being here. There were a lot of back and forth on that and a lot of different issues. So yes, in Stop TB, we had a sort of Bible on which we all say that we should not participate in panels in which civil society and countries are not represented. But for this situation, there was a situation. So anyway, that's where we are. I recognize what you say very much in terms of the role of the civil society. And we actually we have a very good mass of networks of survivors and civil society and communities at national level. Is not as big as other communities, but it's very relevant in most of the high burden countries. We are in a very different place than we were several years ago. The challenge, and you pointed it out right, is that the funding available for them to not only exist, but to survive beyond the 1 year funding or so, and also to be able to be empowered and to have a meaningful engagement in every process that is happening, because without having at the table those for which we work, none of the thinking that we have, as much love or empathy we can have, you cannot replace the expertise and the suffering that people went through being having TB. So creating programs and interventions for people with TB or survivors without them at the table doesn't work. So we have a critical mass there. You pointed it right. The only funders are actually USAID, which is the bigger funder for Challenge Facility for Civil Society, as well as the US government for Global Fund. And we get a little bit from the Global Fund, which gives us some amount to distribute. It's around $9 million a year. It represents 20% of what is needed. So we are trying to push for getting more, but this is the level of funding that we have right now. To create the movement that Sumia said, you need indeed a critical mass there that, people as well, demand generation for people to get access to these tools. And without having enough people well equipped and educated to do that, it will be difficult. So it's a lot of work in progress, but we are not yet there. Thank you.
Thank you. Time flies. One last direct question, and then we.
I think I can speak now. Oh, okay, here. Thank you. Thank you so much for the opportunity. Thank you for the insights. My name is Liz Ntonjira. I'm the Global Communications Director at AMREF Health Africa, one of the leading health development organizations in the Global South. My question, or really it's a comment, it permeates from what Lushisha was mentioning about having the same peers in the same conversations, etc. It's really unfortunate there is no representation from the Global South in this conversation, in the panel. And we know that TB affects mostly people from the Global South. My appeal is when we have these sessions, let's have the people most impacted in these rooms, learn from them, understand what are the pertinent issues. I understand funding has been brought up, but what are the other issues that need to be addressed? Thank you.
Yes, well taken. And we will come to that in, yeah.
Thank you very much. And my name is Gidado Mustafa. I'm the Executive Director of KNCB Tuberculosis Foundation, Netherlands. I just want to add my voice to all the important issues raised, and I'm taking it from another arm. I think we have discussed quite a lot around the arm of funding, but I think there is also an arm within the TB program in general that I think younger generation should help us do, because we are also suffering from self-inflicted problem. Self-inflicted in the sense that we don't have sense of urgency and we don't have sense of going to scale. Everything we want to do it timidly, piloting it, taking it to scale, national, subnational, district, community. We take our time. With the gene expert, it took us 12 to 14 years. It's still less than 40% coverage. Better call it, every single opportunity that comes, it will take the TB program 2 to 4 years before we will reach the last mile. And before we arrive the last mile, it has changed.
Yep.
So we start again all over. We start again all over. Again, before we reach the last mile, everything has changed. So I would really sincerely would like to plead to the 3 stakeholders. One is the Ministries of Health and the National TB programs. We must see things with sense of urgency. And if you can't go to scale, go home. Number 2 is to the donor environment. The donors are also not helping matters. They will say you must optimize before you go to scale. It cannot work that way. You are eroding sense of urgency. I counted the fire service companies in Germany and all the institutions. They are not quenching a single fire in the last 6 months, but people are being paid salaries and all the vehicles are being foiled. Therefore, we must see things at scale if we need to end TB in our lifetime. Last but not the least is also the technical agencies. You must transfer the capacity to avoid dependence on you. We must transfer the capacity to people who are really on the ground if we will be able to do this work at scale. My point is, go to scale or go home. If not, we can't end TB in our lifetime. Thank you.
Thank you. We come to the general discussion anyway. So yes, I did not say that it is unimportant. Yes.
Right.
I think
I like Luchika when she responded that people may not know about TB, but I'll say something about knowledge. People dealing with TB must work and make sure it's known. 2, funding. As Zimbabwe, during COVID, we did not get any single vaccine from Covaxin or anyway, we bought cash. This must be clear. So when it comes to these researches, the donor community is very good, but nowadays, let's change the attitude as poor countries or Southern Africa or India or whatever. Let's run the researches themselves. I want to challenge you guys. Give it to us, Zimbabwe. I head the Ministry of Health of Zimbabwe. Bring it on. We can run with the researches together starting now.
Thank you. So the urgency is more than clear, and everybody, I think, agrees here. I have to tell you, I've been in the TB field for 30 years or so. In the original phase, I was considered as a provocative, blunt German, and now I see the frustration is everywhere now. We need to speed up, and I will not go into vaccine details because I think we leave the last minutes for this kind of discussion. Just to say, TB vaccines have been as slow as all other aspects in TB. They are more complex than COVID-19. We don't have a neutralizing antibody that solves the first round of issues, at least. There are about 15 vaccine in clinical trials, and we need RNA vaccines, and hopefully these will come with the support from the smaller, small was in the past now from the companies. But I'm afraid I have to agree with Mel, 2030, we may not be at the end of the game. And I'm currently, well, I probably really, since we only have 15 minutes, just give the word to all the panelists to talk about or give very precise comments to what we heard. And I would repeat what Luchika said in the beginning, what you said more or less towards the end, and many, many others said. Time is running. Not only for that session, but for TB. And we are in the last round, and since 30% have been achieved, let's say, we should not give at this stage and rather take that as an incentive to go on with accelerated speed. Let me start again from the same side. Please be short because we're thrown out of that room in 9 or 10 minutes. So yes.
Yeah. I'm always difficult to be thrown out, but yes, I know. And I will use this to make a point clear. So I'll stand up just because I want to see the room. I want to say something. End, eliminate, and eradicate are 3 different things. And I want all of us to understand that by 2030, what we want to do is to end TB. That means, and it's an understanding and so on, that we decrease the level that at a point that global, the average is around 10 to 12 per 100,000. Okay? That is what end TB means. It means we will still have, if you do the calculations, if you go to an average of even 10 per 100,000 at the billions we will still have cases. Okay? So it's not elimination means that in some parts of the world it's eradicated, but it will still exist. There is an old definition for TB, which was 1 case per million. And I am using this time for this, I will not speak more. Eradication is when we have not at all. So just to be very clear, eradicate TB, forget about it. I think bad news even for you, but there is not in the plan to eradicate till 2050. The very young here, maybe. Me, forget about it. Eliminate. I'm sorry that even eliminate for me and some of you, no. Ending TB, which means going to the level, as I said, of 10 per 100,000. Maybe we don't go to 10, but I think that on average we can go to a comfortable level to make it manageable. So that's the entire idea. So for by 2030, what we want is to decrease it enough to go as close as possible to 10, 12 per 100,000. Just that's what I'm here, that you know.
It's so lively. It's not a discussion, but it's a kind of real advocating.
Yes.
Mel.
A thought on the table. Can we push for a global PEPFAR type system dedicated to TB alone, for whether we strategically call it elimination, eradication, et cetera? Don't want to get caught up in those sort of numbers, but to push for that at the highest levels of government through a body like the UN with enforceable commitments, depending on the size, et cetera, of countries, to fund everything from basic research through end game implementation. There are many other ideas, but we need to come together as a community to forge 1, 2, or whatever number and push together for those type of programs. Thank you.
I would fully endorse that, Mel. I think we need that kind of global commitment and coming together with a singular focus on finding new tools as well as using the tools, implementing, because we have gaps in both areas. But I would again say a couple of things. One, that the middle income countries where a lot of the TB is currently present can do much more and should do much more. All countries, I think domestic governments have to take more responsibility, especially if it's a big burden on their citizens, because when we talk about universal health coverage, then if we're not providing access to diagnosis and treatment for TB, then we're not achieving universal health coverage. And when you look at access and treatment, particularly for MDR TB, I think our friend here mentioned that the molecular tools are still only available to 20, 30, 40% of people globally. And so we need to scale that up. We need to scale up access to treatment. But we have to do it in a way in which I think the communities came up, and thanks to, members of the audience, because clearly communities, have to play a major role. Working in India, I know that there's still stigma and discrimination against TB in many places. And so we have to also address that and make sure that the right kind of information is. And finally, I think we still need a lot of research on TB. And as I mentioned earlier, what is the natural history of TB and the immune, the protective immune responses. I think if we can understand that, so we need a lot of investment on the upstream in order to then feed into the downstream actual tools. Thank you.
We really need it all. Willow?
Thanks. Sumya, you already stole my thunder about middle-income countries' own resources. So interestingly enough, I'm probably the youngest of the group here, not physically, but in TB, even though I've been in TB for 10 years, which tells you something. No, Lindsay was in TB before me.
Age.
But age? No, of course. No doubt. The question here to me is, this reminds me, I've been a bit further away from TB in the last 2 years because I moved to diagnostics and COVID was so over-empowering. But this is a little bit of a deja vu. We're still explaining all the things that are going wrong. We got tools, we got 146, we got molecular tools, we got vaccines in the pipeline that we never had before. Yes, I know it's hard and there has to be a lot of work done. That's our job. Why complain to the world about our job? But we know we can do it, it's there. I think we have the tools. We just have to think big, and we have to go out with that solution driven in mind rather than leading with some of the downsides of all the hard work that still needs to be done. And that's something I would leave you all with. Go out and explain we can solve it. And no, non-experts don't have to has to know all the details. They just need to know it can be done.
Thank you.
I was hoping we might come back to the dialogue between our friends at J&J in the front row, but I think, we've heard a lot about calls for public funding, increasing public funding. If we look at the landscape of who is spending money on TB research and development right now, it's 60 to 70% coming from public and philanthropic sources, right? And we heard all the great work J&J did to bring bedaquiline forward, but they didn't do it alone. They did it with incredible partnership and resources from the public and philanthropic organizations. TAG did an analysis to try to quantify public and philanthropic investments in the development of bedaquiline. And we found that the public invested 2 to 5 times what J&J did. To help us understand how to optimally combine it with other new and repurposed drugs to shorten treatment. And so I think when we're talking about public funding and what we need to really move the mark on TB in terms of research, we need to make sure that what is coming out of these efforts are considered public goods. And yes, we've talked, there's lots of barriers, lots of problems, but we can take price off the table as an issue if we start treating these public health interventions as the public goods they are. Thank you.
Thank you. Carlos.
Yeah, and along those lines, my closing comments are going to be on the importance of this extreme collaboration among the different entities and a collaboration that is transparent and candid from the beginning. And the importance of this collaboration also coming with the global South. And we are currently opening discovery satellite centers in South Africa and Cape Town to ensure that the science, the basic science, is coming where the source of the or the majority of the challenge is. And similarly, in terms of implementation, we're doing a lot of implementation research with countries in Southeast Asia, in LATAM, in Africa, to ensure that those insights are coming again where the burden of disease is, and again calling to that extreme collaboration, transparent one from the beginning, so expectations are clear on all ends when we start these development programs. Thank you.
Thank you. So you know what, I would suggest that we close the official part. Some may want to go and find their place in the opening ceremony, but I would encourage you also grab these people on the floor here, talk to them over the last couple of minutes. I want to thank everybody. I think this was good. I learned also lessons, and I will do my best that they are translated to next year's meeting if TB is on, which I, for obvious reason, hope and will fight for it also. But thanks again to everybody. This was very, very, very good.